Welcome everyone to this episode of Manufacturing Talk Radio. I'm Tim Gritty, and I'm pleased to be here with Nancy LeMaster, who is the committee chair for the Hospital Purchasing Managers Index that we talk about every month. Nancy, I've been looking over the report, and I'll let you explain it to the listeners and viewers. It seems to me to be going in the right direction. Nancy, thanks for joining us.
Oh, thanks, Tim, for having me. Yeah, it was kind of a dramatic month. Let's start talking about volume. What was going on with volume this month? So as you saw, the hospital PMI dropped 7.2%. So it's still growing, but it's down to 56.9 from 64.1. So two factors hit that really hard. Business activity dropped by 20% from 74 to 54. And new orders dropped 18% all the way down into contracting at 49. So what is that? So you're right. In a way, that is good news. And you know, at first I thought, oh my gosh, I'm not sure we've seen this dramatic a change in 1 month, but that wasn't true. I went back and in January of 2021, just as kind of going January after that big Delta surge, we saw a similar pattern. 6.8 drop in hospital PMI, 18% drop in new orders, or in business activity, 17% in new orders. And I think, you know, this really reminds us, Tim, of what a good leading indicator report these ISM reports are, because they're not saying the hospitals are busy. They're saying relative to the previous month, we're beginning to see Omicron let go a little bit. So, we really think this is the beginning. Again, a data point doesn't make a trend, but the last time we saw this kind of pattern was when we started to see the recovery from Delta. And then we saw kind of a steady build back. And if you look at the backlog of orders, they went up 1%, so 68.5. So there's demand out there for electives. And I think what this month was saying is that we were starting to turn the corner of the volume declining. So we weren't seeing the level of business activity in new orders relative to January, but you knew from the comments they were very, very busy still. And a couple of really concerning comments, things that we have to watch as we try and get back into this more, relatively speaking, normal pattern and more electives, was comments about having to close beds because of staffing shortages and concerns about putting off elective procedures because of blood shortages. So that is, you know, we have the lowest level of national blood supply that we've had since World War II. So the blood shortage is really becoming severe. Now, you know, all of the collection agencies, Red Cross, all the others are working really hard to get people back. And I think as we see the Omicron starting to diminish some, that's going to happen. And the other silver lining in this month was that employment number. I know you saw that, up 14%. So we went from about 7 months of contracting to finally a month of growth, 53.5. Again, doesn't make a trend, but it's a good piece of news. And what the comments said were that incentive programs that hospital providers are putting in place to help retain staff, to help get staff, are starting to work. But the other one that was really, I guess, gave me some hope was a comment about people being willing to work in hospitals again. And, you know, you and I talked about your housekeepers, your food service, your supply chain techs. You know, they can get jobs anywhere. And if the environment is starting to get a little bit more stable, they're starting to feel a little less risk related to the Omicron virus or COVID in general, that could bode well for our employment, our ability to recruit and hopefully retain employees.
Well, it was interesting to me what you said about the national blood supply. That's kind of a shocking statistic, and I have heard about it nowhere at all.
You know, and then that's been a really frustrating thing. And within, you know, the healthcare world, you know, ARM, the Association of Healthcare Resource Materials Managers, they put out bulletins frequently, and we've been in the red for a long time. And I've heard of some local cries and, outcries encouraging people. It has gotten very little national publicity, and I'm not quite sure why, but it is something that I know that locally places are working very hard to get people back out, donating. When I was doing the release this morning of the report, one of the reporters mentioned getting an influx of calls and emails because they hadn't donated blood or platelets for quite some time. So I know there's outreach going on, but it was the first time I actually heard the hospital say, hey, we might have to continue to postpone certain types of elective procedures based on availability of blood.
Wow, surprising. So let's kind of walk through what may be causing these rather drastic changes in the report, which I found amazing. Overall, I read the report, felt like, phew, it sounds like, feels like what I'm hearing is that COVID is moving on. But let's just kind of walk through each of those, Nancy, in detail, because I think it's important to our listeners to understand what those shifts are. And you can begin with new orders, which people sometimes don't exactly understand in the hospital world.
So when we think about the metrics as they apply to hospitals, they're a little different than manufacturing and some other services. So business activity we think of as people in beds, what's going on in the hospital right now and in the emergency room right now today. New orders are things that are being scheduled. So you might think of, they could be elective surgeries. And remember, the word elective is very, very misleading. There are people who have cancer that need tumors removed that are having to postpone that. Things that you and I don't think of as electives, hips and knees. But the definition is, can it be postponed 30 days, without some emergent effect on the patient? So these electives are very much procedures that need to be done. We're not talking about plastic surgery here. We're talking about, cataracts being removed, joints replaced. So those, it might be a radiology procedure, an MRI. Those are new orders, okay? People that are placing those orders, in essence, they're scheduling, say, for next month. They're getting their order on the calendar. Backlog of orders, just like we think of in manufacturing, are, a metric of, I've got people, a physician maybe have people that I need and want to schedule for a procedure, and there's no availability, there's no slot right now. So I'm maybe pushing those out. That can be a little subjective, right? It might be, I can get them scheduled, but not for 3 months, but that would be considered a backlog, right? I can't get them in the next 30 days. So that's kind of what's going on. So what the numbers really said is relative to the prior month. So remember that it's a relative scale. Relative to January, we have fewer people in the house, but we also have fewer appointments being made. And that's not really as unusual as it sounds, because remember, we've been fooled many times with COVID. We think it's going to decline and then it bounces back. And as we've said, you can't just flip a switch and change out units. So there is a bit of a lag between seeing the COVID patients decline and seeing these electives fill their spot. So what it's telling me is we're starting to make room for those folks, and that's a very good thing. So that was kind of the volume piece, and we saw the employment improve. So that gives us, okay, hopefully we're going to have the staff to take care of them. Right. And then we got to move over to the supplies, right? Are we going to have supplies to take care of them? And the supply picture this month wasn't as dramatic. You saw that, things kind of shifted, but, supply deliveries did get worse again. They went to 71. And no, they got better. They went from 76 to 71. So they got a little bit better. Inventories, we're still building inventories, but not as fast. That was 56 versus 61. The sentiment is that inventories are too high, but all the comments keep talking about the back orders. In fact, I was listening to a webinar with some large hospital system supply chain executives, and a very large system. But anyway, they indicated they were dealing with more than 8,000 back orders a month.
Oh, my.
Yeah, a month. And so, multiple hospitals, but still, that tells you that the supply chain people are doing nothing but firefighting, trying to get products in the door. So it isn't getting worse. It isn't getting significantly better. They're still building inventory, even though they know it's too high, trying to protect themselves in case of another surge, or in the case of bringing back electives, the mix of supplies is a little bit different. So they've got to, be looking out to what they may need for that. So, there's still a lot of price pressure out there. Pricing was up 1%, 75.5 versus 74. Pharma and supplies individually, tiny bit better, 61 versus 63, 75.5 versus 78.5. So, if I take all that jumble of numbers and say, well, but what's the story? I think the story is the supply chain is stable at the moment. It's not getting worse. It's not really getting better. It's certainly not where we want it. I think, the story with the manufacturing, right, was still, you've got the pressure of raw material shortages, labor constraints, more demand than supply. That's carrying right on over into the hospital sector. And I think people are dealing with it because they've been dealing with it now for years, literally, and making it happen. So the supply story doesn't cause me to be worried that we can't handle that influx of elective procedures as the COVID starts to rescind. It would tell me that these folks are going to be able to cope because they've learned how to cope with this. The blood being the exception, that could be a real worrisome thing, but that wasn't widespread comments. So we're going to hope that that's more spots across the country, not broadly.
Nancy, I'm just curious, when it comes to imports and exports and inventories, are imports helping us at all, or are you seeing, or the hospital seeing, a shift towards more domestic supply?
So imports were up 54.5 versus 50. What I hear is that there's still not enough domestic capacity. I think hospitals are buying where they can. A very telling metric that was up this month was days payable outstanding. And it went from contracting to growing, up about 8.5%. And the comment was, in order to deal with these backlogs, these shortages, these substitutions, they're still buying from kind of secondary suppliers, which causes a challenge in the payment cycle. A lot of times there'll be errors or just things have gotten done quickly and they have to be cleaned up to get bills paid. To me, that's an indicator that we're still in this mode where we're getting supplies wherever we can get them, and we're still in more of a reactionary mode there. So yeah, imports are still, critical at this point. Again, there's a lot of talk about increasing domestic supply, and there have been plants, Becton Dixon, some of 3M, that have definitely increased their production capacity in the U.S., but they already had manufacturing plants here. So, I think that's going to be a long-term transition, but for now, I think people are they're finding a way. They just find a way to get it done.
I know that in every one of these instances, particularly in the healthcare industry, but also in manufacturing and non-manufacturing, when you have a significant disruption like this, because in this case of a pandemic, it's followed up by lessons learned for next time. Mm-hmm. Has that discussion already begun?
It has. It has. A really interesting group has formed, and it's the it's kind of the Health Industry Resilience Collaborative. And it's been healthcare providers and some suppliers coming together voluntarily, just coming together to really talk about what needs to change going forward. So a lot of talk, no different than, I think, Tim has mentioned, but the idea of visibility to second tier suppliers and a better understanding of where supplies come from. Now, the healthcare supply chain has always kind of lagged a little bit. And, we put a lot of trust in the manufacturers and the distributors to manage things for us that I think that we understand today we need to do ourselves, that we need to do a better job of internal demand planning. We need to do a better job of risk mitigation planning. So you're starting to hear a lot more discussion about, the risk of sole sourcing. The risk benefit, how do we contract with manufacturers and take into account not just the price, but the availability? And how do we do a better job of, there's got to be a trust factor. The manufacturer's afraid that if they tell the provider, hey, our capacity to produce is down, or we're having a raw material problem, then the hospitals are going to hoard, right? And make the whole problem worse. And that the hospitals are saying, well, wait a minute, if you wait until you don't have any to tell me, I can't put conservation, procedures in place. So I think a lot of talk about how do we do a better job, both sides being accountable for managing that supply chain, not hoarding, not waiting until a manufacturer's in crisis to tell its customers there's a problem. And how do we do a better job of this concept of conservation planning? So, we know that when things get really bad, there's more than one way to do things, and that we can reuse, sterilize and reuse masks, and we can conserve PPE. But how do we have a more formal plan and sort of that almost a stoplight? Okay, it's yellow. Okay, let's start conserving now and see if we can prevent it getting to red. So I think there's a lot of discussion going on about what did we learn.
Well, that's interesting. The automotive industry is going through a similar catharsis because of chips.
Right.
And now the big chip manufacturers, including Taiwan Semiconductor, are building plants in the US, and the automotive industry is saying, whoa, we're not going to just say, oh, manufacturer, make it for us. We're going to begin to manage chip manufacturing, just like hospitals are now saying we're going to manage and work more closely with distributors and manufacturers, and our expectations of the supply chain. I'm glad to hear that's taking place.
Yeah, it really is. I think that one of the things that happened during this whole pandemic is the supply chain executives, the chief supply chain officers, became much more visible to the CEO, and they talk about them being part of the C-suite now and being more engaged in helping the hospitals think strategically about how they do manage supplies. And so that idea, that sort of elevation of the profession, which maybe in manufacturing happened a long time ago. People are like, gosh, if we don't have supplies, we can't make products. Well, guess what? If we don't have supplies, we can't take care of patients. So I think bringing it into a more strategic realm has been something that has come out of this, and hopefully, our supply chain professionals, I know they will rise to the challenge and start helping their organizations think more strategically, so we're not just reacting to these kind of things.
Nancy, is there anything in the report that is alarming in a negative way, as opposed to where we were a year ago? I mean, every variant clearly caused a major ripple. Going forward, is there anything alarming in this report that it's to watch out for?
Yeah, I think that like in all of the reports, the employment, the labor component is something we're going to have to really, really watch. It was great to see it get better, but I think that is going to be our constant watch. I think that we're on that slow, long haul of getting better in terms of supply availability. It's just going to take us way longer than we thought, but the labor is going to be our Achilles heel. If we can't get folks, if we can't get caregivers, and if we can't get support staff, we can't take care of patients. So that's going to be what we watch. I think the thing that on the other side is an extremely bright spot was during the State of the Union address, when President Biden talked about the test and treat strategy going forward. which would allow people to go into pharmacies, be tested for COVID, and if they test positive, get a prescription for the antivirals. I mean, you and I talked about long ago, I said the antivirals are going to be our savior in this thing, because if we can keep people out of the hospital, that's what's really going to make a difference. Well, if you have a plan that allows people to be tested and quickly prescribed these drugs that can minimize the impact of COVID, the likelihood we can cut down on the number of people being seriously ill, hospitalized, and die from this is very, very positive. So I think that, if we can grow that program and we can actually get COVID to a place it's like the flu, where we can diagnose it, we can provide antivirals, and yes, you will have a small group of people that will always end up hospitalized from it, but it's manageable. That's going to allow society as a whole, and the hospitals in particular, to get to a much better place.
I know that you have a lot of contact with the rural hospitals, and they, of course, have struggled but managed through. How are they doing presently?
It's still a significant struggle. They struggle to get labor. One of the downsides of coming out of the pandemic, where there were a lot of states that made emergency declarations, and that allowed us to waive certain requirements, and the federal government also. And the American Hospital Association and other organizations are lobbying for some of these changes to become permanent, because they expanded access to telehealth, and they expanded some of the resources available for rural hospitals. They expanded some of the capabilities for pharmacists and nurse practitioners. And really, those are expanded capabilities we need ongoing, because the strain on the rural hospitals is just there. It's going to be there. It's very hard to get labor, and they struggle just financially. Although they do get some preferential reimbursement, it's not enough. So we're really hoping. I think that the programs and the bonds that were built, the dynamic ventilator program, where we loan ventilators to each other across the country, I see that staying. I think there may be some other programs like that we're going to try and develop as an industry through the American Hospital Association and other groups. But we really need to embrace the technology that's available today and use it to be able to help these people that are in areas where it's very hard to physically be able to see, especially specialists, and they can connect with these people, mental health professionals. All of that is really critical, I think, to being able to meet the need of the rural hospitals. And I think now we've demonstrated that there is acceptance and it works. So we have now taken it from a theoretical benefit to one we can show, and hopefully states and governments will respond with positive rules and regulations that help us do that.
Another area that you have brought up, and quite interestingly so, is licensing, and whether or not someone licensed in Missouri can cross the street and work at a hospital that happens to be in Illinois, because St. Louis is a divided city by a river.
Right.
Has that been embraced, where the federal government and even state licensing boards are going, whoa, we didn't see this coming. There's one we have to wake up to?
I'd say it's mixed. You've got, you always have that federal government, state government control argument. So there are those that say, we need just federal national licensing instead of state licensing. That's a controversy. You have some states that are very progressive. They get it. They're very much changing things. And you have some states that are very protectionistic yet, and they still don't quite understand that it's not in their best interest to be that way. It's going to be slow coming, but I do think that people are aware now of the need and the demand. And, I see it coming. I just unfortunately don't see it coming easily or quickly across the country. I see it happening in spots.
Yeah, it's almost disappointing. I know that My driver's license is good in every state of the union, and I can get a ticket in every state of the union.
Right.
I'm not sure why the hospitals, the state governments aren't taking another look at this. And I'm sure that there's not that great a disparity in what the licensing requirements are in New Jersey versus Nevada. I hope that they come to the point where we can have labor more fluid for these kind of prices. And I appreciate you looking into that and keeping us up to date on it, Nancy.
Will do.
Well, thank you again for joining us. This report is always very revealing, and it's always, to me, very interesting because we're talking about a system where you can actually measure purchasing and what flows through it, but in a very different and unusual way because it's a healthcare industry system and not what we think of as manufacturing or services. So thanks again for joining us.
You're welcome, Tim. We'll talk again soon.
We will, and we always thank Nancy LeMaster for joining us from the Institute for Supply Management. You can find them at ismworld.org. And while you're surfing around the web, check out jacketmediaco.com, where you can find links to this show and all of our other podcasts. And as always, thank you for joining us on Manufacturing Talk Radio.